Well, at last we've come to putting it all together. All of the work that you've done over the course of the semester, all of the different techniques that you've learned, and critical thinking skills that you've learned, the way of applying new knowledge and old knowledge in a new role, and new knowledge in a new role, is finally coming to fruition, and you're beginning your journey to PC1 and diagnostics with a new set of tools. So today we'll be talking about all of these tools, kind of reviewing the sequence of using them in the clinical setting, and hopefully helping you prepare for your final checkoff. It's important as we think about this to consider the general guidelines that the clinician considers as we approach the assessment of the patient. While our approach is disciplined, and certainly we have to learn a sequence so that we're accurate in our assessment of patients over and over again, there has to be some flexibility to it. There's an old risk management adage that says if we do the same thing each and every time, then we're likely to get the same result. So the more proficient you become in your assessment skills and repeating those assessment techniques over and over, the better you'll become, and the better diagnostician you'll become. However, we have to realize that everybody that walks through our door is going to be different in function, in the way they present with disease processes. The way we would assess a baby is very different from the way we would assess a geriatric client. In the case of the baby, of course, we would want to do those procedures that require quiet auscultation to take place first, because once the baby becomes suspicious or upset, then it becomes more difficult. If we're working with an older adult that may have cognitive issues, then our approach certainly would be different there as well. Again, I cannot stress how much the history is important, how important the history is to determining the correct diagnosis, or at least coming up with differential diagnoses from which to choose. Be sure that you take a careful history. The physical exam really becomes just a confirmation of what you already suspect, or perhaps the assessment rules out what you suspect. So the two work in tandem to help you be more accurate in your diagnosis and treatment of the patient. Always respect patient privacy. This is something that should never be foregone in the clinical setting. Make sure that the patient, once you've established a rapport with that person, is given adequate privacy. If we're going to do the well woman exam, we want, of course, to step out to allow the patient time to change. The rush of a volume-filled day should never forego respect for patient privacy and patient dignity. Maintain calm and balance in your demeanor toward all patients. It's important to become comfortable in your own values, your own biases, and not allow those to color how we treat the patient. Everyone who darkens our door deserves to be treated with respect and with dignity, and so we want to make sure that we have our quote-unquote game face on as we go into the patient room, because certainly people may have different value systems than we do in our own personal lives, but that does not should not preclude them from getting or exclude them from getting the best treatment possible given our resources. Revisit problem areas. Once you've finished your history taking, go back and ask the patient, now, I understand that this is a problem. Did I get that right? Be sure that you go back and confirm with the patient what you perceive as the problem. Sometimes a second asking may clarify a point, or if you're not clear on something, ask them again, perhaps in a different way. Sometimes patients, as you progress through the review of systems, will think of something else they forgot to tell you when you first ask about it. Just going through that review of systems or asking a question in a different way may jog their memory and elicit some important information that will help you with your differentials and certainly guide you in their assessment. Accuracy is, of course, what we're after. As I mentioned, if we have a certain way of proceeding each and every time, we hone our toolkit and become more and more proficient. However, there are some things that affect accuracy. Sensory deprivation, in other words, if somebody doesn't get a lot of sleep, or if they have a neuropathy, or they have visual problems, their perception of their problem may be quite different than what presents in the clinic. Emotional constraints. If some of these may be apparent or unapparent, some may be fearful of being in a physician office, or they may feel they'll be judged, so they don't give you all the information. Or certainly in cases of abuse, sometimes things are left out. The astute clinician watches for these signs, and it's sometimes what people don't say that really gives you the tip off to something that's going on with the patient. Trust your gut on this, because as clinicians, you'll just sometimes have feelings about things, and while we certainly want to go with empirical information when we're treating the patient. We look at labs, or we have certain assessment findings. There's something about that gut that tells you when something's not quite right with a patient. So be sure you revisit those areas about which you have concerns. Language barriers can certainly be an issue as well, as we've talked about. It's important to have the ability to get a translator, whether that's in person or using the translation line. Try not to use family members if you can help it, because this really puts them in a bad spot, and sometimes you don't get accurate information from them if they're embarrassed about the topic of conversation, or perhaps they might not reflect it in a way that's going to have meaning for you as the clinician. Cultural barriers, be sure you're aware of the different cultures that you'll be treating in your practice. It's always important to really look at the demographics of your practice, and be sure that you're aware of any health / cultural issues that may come into the clinic, because this can affect our treatment. Just as an example, the Hispanic culture, the men tend to be very stoic in their approach to illness, and so we may not get the true picture by listening to what they say. We may have to look more for grimacing or other signs of illness. Other cultures, some of the Asian cultures, are not demonstrative verbally or with their body language, so we may not see that totally. Others may be very histrionic in their approach to illness, and very emotionally demonstrative. So just be sure you're aware of any cultural barriers, and who is the spokesperson. Sometimes some cultures, there's an appointed family member who is like the person that gives you the information about the patient, in lieu of the patient speaking for him or herself. And so you have to be somewhat sensitive to that and tuned into that as you perform your assessment, and certainly as you obtain the history. And of course, we have the unresponsive or the cognitively impaired, the comatose patients. So these all can affect our accuracy as clinicians, and we need to be aware of those factors. And of course, because we're all human, there is this the potential for error. Every observation has a certain sensitivity. That's the assurance that if something is to be found, it will be found. That doesn't always happen on the first visit. So, or especially if it's a patient that's new to you, you may have to see them a couple of times before you really get to the root of the problem. This is particularly true of patients with certain psychiatric issues. We may think it's one diagnosis, but then it totally ends up being something else, depending on their presentation in the clinic that day. Every observation has a certain specificity that's the assurance that if it's found, it's a true finding and not a misinterpretation or false positive finding. So numerous things have impact on this potential for error, and we have to be aware that it's there and carefully go back over areas of the assessment or the interview that could potentially lead to error or a misdiagnosis. And of course, the potential for error increases with our uncertainty and our discomfort. And this over time becomes a little easier. It's a little daunting when you first begin to operate in your role of nurse practitioner. And as you think back over your time when you were a brand new RN, or perhaps even brand new in the clinical setting as a nursing student, how you had this apprehension about making a mistake or doing the wrong thing or not doing everything that you should. Much of what we learn about our patients comes from the interview and our early assessment findings. If we're not comfortable in our own skin in a new role, that adds to the uncertainty and the potential for error. Secondarily, if we're not proficient in assessment techniques, that can certainly lend to the potential of error. We cannot always express our findings in numbers. Much of it is subjective, much of it is critical thinking, some of it's gut, and over time the three of those things seem to come together just as they did for you as a registered nurse. We can't avoid probabilities. There's a false comfort in the apparent certainty of many numbers, but unfortunately patients don't always fit the numbers. Sometimes it's something way out of the box. One thing that I think is comforting is that we shouldn't look for zebras in a herd of horses, and that is common diseases occur commonly, and most of what we see in primary care is going to be those horses, those common things that we see. Every once in a while we find the zebra or the uncommon illness. So I think that you become very proficient at things that occur commonly in the primary care setting, that is, complaints that we see each and every day. Occasionally you'll find things that don't fit the mold, and that's a time if you need to call on your collaborating physician or a specialist if you're not sure or things are just not adding up, then maybe it is a zebra. But I think we can somewhat offset this uncertainty with the idea that common diseases occur commonly, and that's typically what we're going to see in primary care. General examination sequence, this is a good way to think about it in your mind. Always have your tools prepared. So if you have an MA or somebody that works with you, they'll generally take care of the initial triage piece of getting the chief complaint down on paper or into your EMR. They may go ahead and take the vital signs. My routine is to go in and look at those things, meet the patient, kind of do my review of systems, and if I'm going to ask them to change for a well woman or something, I'll step out. But I've already developed that rapport with them early on in the visit, and generally inspected them, because you can do a lot by just talking to someone and learn a lot about them by watching their body language, their eye movements, their functional ability. With older patients, I like to watch them walk down the hall into the exam room, because I learn a lot about them, and their ability to walk, if there's pain, or if their posture is poor, or they have difficulty with mobility, if they have a mobility device. General inspection can occur kind of simultaneously with your interview process. So a lot of that's done then. Being sure that you're prepared with the correct instruments, having your stethoscope available, making sure that your ophthalmoscope, otoscope are available, all of those things, and that measurements are recorded, and make sure that the blood pressure is taken and recorded, that the temperature is taken and recorded. All of those things are very important. With adults and adolescents, the general inspection looks, as I spoke about, just the general appearance. Look at the skin color, hair distribution. What is their facial expression like? Are they expressing pain through grimacing, or perhaps they don't make good eye contact? What is mobility like? Or do they have a walker sitting by them, or is there a cane in the corner? I always look at people's footwear and see what kind of shoes they're wearing. We treat a lot of diabetics in the clinic, and if they come in and they have open-toed shoes or sandals and they're diabetic, and I see little places on their feet, then I know later on I'm going to need to do some close examination of the feet and some teaching about proper footwear. Just an example. Dress and posture. Is hygiene appropriate? Did they brush their hair, or do they, have on clothing that's clean, or is it neat and appropriate for the season that we're in, or is it not? This could, of course, indicate in an older person maybe some cognitive decline, or even an infection, maybe some delirium has occurred. I listen to speech pattern. Is it halting? Is it slurred? Is it, are they having difficulty finding words? If they're having a barrier with language, do I need to get the translator in there, or get the language line available? Do they have difficulty hearing? Are they understanding what I'm saying? Do they have assistive devices like hearing aids? Their stature and their build, I look at that, and certainly, in my diabetics, I'm looking at the shape of the body. Do we have a large waist circumference? Or in my COPD patients, or people with heart failure, these are things that I'm really looking at. I look at musculoskeletal deformities and note those. If they have missing like digits, or I look at the fingers, do they have the big nodules on their fingers? Any of these things that could indicate a problem with function, quality of life for the patient. So these are things that we get while we're talking to the patient, largely while we're doing that interview and review of systems. I'm doing a lot of that ahead of time before I ever lay a hand on the patient. And you can see here the picture here. We observe this gentleman. He has a nice hair distribution. The skin looks even in tone. He has a nice posture. I notice that his hands are hanging at about the same level, so that tells me that more than likely the spine is straight. I can't see a side view of him, but it looks like he has good posture. Footwear is appropriate. It looks like he has a good supportive shoe on, and it doesn't look like he's wearing the toes inward or outward. It looks like he has a fairly even distribution or even stance there. It would be interesting to watch him walk to see if there's a limp or anything, but the pelvis looks fairly even. So those are all things that just as I'm visiting with this person, perhaps even in the hallways, I say hi to him. These are things that I look at. I look at his waistline. He for his size, he looks maybe a little bit, I would look at his BMI and his weight, and we might talk about diet and healthy exercise, but he doesn't appear to have any edema. The trachea appears midline. So those are all things that I would kind of notice as I looked at this gentleman when I first meet him. Vision problems, if he had on glasses, we might ask about when was the last eye exam, or if he had a cane. Eye contact with the examiner. Does he look me in the eye when I'm talking to him? Is he oriented and alert? What's his nutritional state? Does he have any respiratory problems? Is he coughing or wheezing? Is there a significant other that accompanies him to the exam? And what's the interaction like between those two? especially parent and child. This is a big part of the pediatric assessment, is really looking at how is the parent relating to the child, and does there seem to be a bond or appropriate interaction for between the parent and child, just as an example. Respect modesty, and you want to, especially when you're going to do the well woman exam, or a genitalia exam on the male, or a prostate exam, make sure they've emptied their bladder. Of course, this is a good time to get the UA if you're going to do that, especially with well women. That's what we do in our clinic. Remove as much clothing as is necessary and put on a gown, and be very specific about what you want them to take off, especially if it's a first time for a female exam. Explain up front what you're going to be doing, and then how to put on the gown with it open to the front for a breast exam, as an example. And ask for a chaperone if you think it's necessary. The MA in our office will sometimes come in, if she has time, to be with us during male and female genitalia exams, and that's our practice. It doesn't always happen. It's advisable, if you do have someone, for them to come in, particularly if you're of the opposite gender of the person you're examining, but sometimes that isn't realistic. Here are some measurements, and this is just the beginning of a suggested sequence for you. And as I mentioned, the MA can do a lot of this, and many do. As in our office, the clinician does not measure height and weight or do the vision screening. The MA does this. They get the vital signs, the temp, pulse, respiration, and blood pressure in both arms. If it's a geriatric client, we have them check for hypotension when they sit to stand, or that as well, so we can check that out. Those can largely be done by the MA or the provider's nurse. When the patient is placed in the room, and again, I always go in and say hi and develop my rapport with them early on, and if they're going to have to change, I go ahead, depending on what kind of visit we're going to have to do, get them into a gown and everything ready to do the inspection. I like to go in and do the review of systems and kind of my history, so that I have initial rapport with the patient, so when I come back in after they have had the privacy to change into the exam gown, they already know me, and they know that I'm invested in their health care, and there's already a degree of rapport, even though I haven't assessed them or placed my hands on them yet. I begin by looking at the upper part of the body, looking at the head and the face, assessing eyes and ears. This is when I, of course, use my ophthalmoscope, my otoscope. We're doing the cardinal stares. We look in the nose, check patency of that. Look in the mouth and the pharynx, examine the neck, the thyroid, look at the upper extremities. This is when I do my lymph node checks. If it's a female, I will also do part of the breast exam while I have them seated, so I can go ahead and get that taken care of. I'll take a listen to the lungs, and perhaps an initial listen to the heart, depending on the age of the patient. And of course, here's our patient that we were talking about earlier. He's seated on the exam table, and so we're going to do our initial exam here with him, an initial inspection. So this would include front and back, head, ears, eyes, mouth, thyroid, lymph, just inspection and palpation, initial listening to the lungs. I'll look at the back, look at the spine, see if there are any spots of pain on the spine. I'll check the CVA tenderness. So everything's done when I ask them to move to a supine position. the back is exposed. We have the back and posterior chest. We're going to listen to the lungs. We look at female breasts, and as I mentioned, I begin my talk about, I do a lot of education and a lot of talking when I'm examining, so that the patient understands what I'm doing. I explain what I'm going to do, and like with the breast exam, I'll talk to them about looking in the mirror and looking at the symmetry of the breasts. So I have my spiel that I go through as I'm examining, and that saves time later on, as we move through the exam. In this case, with the male, of course, I'm going to do my TBA tenderness. I'm going to examine the spine, the straightness of the spine. I'm going to listen. I'm going to, if there's a lung issue, I may go ahead and look at expansion and everything here. Listen to lung sounds with the patient in this position. And of course, we'll examine the thyroid, as you've been taught, having them lean and pressing the trachea over so you can feel the thyroid when the patient swallows. All of those things are done with the patient sitting up. And of course, inspection of the breasts. This is a good time to have them, if it's a female, particularly to lean forward, but the male breast should be examined as well, to look for any nodules or anything of that sort, particularly if there's a complaint of that sort, making sure that that those are addressed. With the patient, then we can, if you have an electric table, this is great. If not, you may have to use pillows, and we inspect the chest in the recumbent position, looking for JVD, pulsations, measure any pressure or JVD distension that you see. This is when we would do that, and of course, just generally looking there at the patient. We're not fortunate enough to have a reclining or a 45 angle, so you would have to kind of use pillows to prop or a wedge to prop the patient up to this if you have a flat table or you're working in a clinic that does not have these resources. With the patient supine, the chest is exposed, and of course this is where you finish up with the breast exam, and I do a lot of education, show the technique for the patient, check out any lumps that she has noticed, or if it in the case of a male, I would do the same. Listen to the heart, listening to all of those, looking at the abdomen, and looking for any pulsations in the abdomen. This might be where you see the aortic aneurysm in the abdomen. This is where you might see that pulsation, so be sure you look at that area. Check the inguinal area, external genitalia in males can be checked here, although I generally do that standing. It can be looked at here initially, and of course you can check for any, you want to observe, auscultate, or inspect, auscultate, light palpation, heavier palpation with the abdomen, feeling for any masses, any areas of pain. And you can also at this time look at external genitalia. With the legs exposed, we look at the feet, the length of the legs, if they're, particularly if there's hip pain. Look at alignment of the pelvis. You can look at the feet, check pulses, look at the bottoms of the feet, particularly with diabetics. This is a good time to do that. Look at any varicosities that might be noticed, any swelling or redness or warmth, depending on the complaint of the patient. This is a good time to do that. This is all done with the patient supine. With the patient sitting with a lap draped, this is a good time to perform musculoskeletal and neurologic inspection. Of course, the testing of cranial nerves, and also many of the lower extremity testing with musculoskeletal, as well as shoulders. This is a good time to look at that. Sometimes if it's lower back, we have to have them stand up and look at, motion, range of motion with the back. But for most of the the exam procedures that have to do with the extremities can be done from the sitting position. With the patient standing, as I mentioned, this is where we look at spine. Neurologic, this is where we look for scoliosis in the younger child. We look at abdomen. If this is where you would perhaps examine for inguinal hernias in males, and generally we'll sit on a stool and a low stool and exam and allow the patient to be covered with a sheet, and so that they have some measure of privacy. This would be where you would ask your chaperone to step in if you're going to use a chaperone, if you're of the opposite gender particularly than the patient. With the female patient, once the basis of the head to toe or basics of the head to toe are done, with a female patient, this is when you would ask her to assume the lithotomy position in the stirrups, and we would examine the external and genitalia, and explaining as we go what we're going to be doing about whether it's looking at the external genitalia and talking as we do that, reconfirming any symptoms that they're experiencing, and then allowing them or talking to them as we insert the speculum and look at the cervix, and then end up with the bimanual exam. But I'm explaining as I go, and before I do something, I'll let them know what is going to be happening. If I'm going to do the recto-vaginal exam, I let them know what I'm going to be doing, and just before it happens, so that they're not surprised when I begin to examine them. This is, of course, the patient in the stirrups. You have to make sure that they're positioned correctly. If you're unable to find a cervix, you may have to, after you get the speculum in, you may have to have the patient put her hands up under her bottom to kind of tilt the pelvis differently, or you may have to have her scoot down just a little bit more. Different things depending on the woman's anatomy. Having her relax, asking them to put their hands on their abdomen, take some deep breaths in and out, or if it's if they're really fearful, sometimes I'll have the MA come in and just hold their hand to help them relax and perhaps distract them a little bit from what's going on with the exam if they're concerned or fearful. With a male patient, this is I do this a little bit differently. Some texts suggest that to examine the prostate in the male, that you have them bend over the table. I personally do not like this because I, number one, think it's a dignity issue, and secondly, it can cause a vagal response that has the person end up on the floor. And I have a lot of older male patients in my practice, and so I have them assume a left lying position on the table. You can examine the rectum and the prostate from that position, and I feel that it lends the patient much more dignity and privacy, as well as it being a more safe position for the patient. But some people still use this position where the patient leans over the table and the rectal exam is done there with the prostate exam. So whichever you prefer or that you utilize your clinic is fine, but my preference, of course, is the left lying position. With infants, we look, of course, at APGAR score, gestational age, anything about the birth history, any congenital anomalies that either present or that the parent is aware of, the degree of awareness and alertness in the newborn, the relationship between the mom and the newborn, the posture, its flaccidity, its tension, spasticity, skin color, all of these things we look at. Physical exam includes palpation of the head and fontanelles. This is generally done with the baby held upright in the parent's arms, looking at the extremities, the abdomen for any masses, and of course the rest of the baby, including the hips with the Ortolani's maneuver, and you want to make sure that there's no dysplasia with the hips. All of the things are done. Looking at the straightness of the spine, any birthmarks that the child might have, any abnormalities that you might see, and looking at their blood work is certainly a precursor to this. To make sure that was done is very important as a precursor to the infant inspection and assessment. There's no right sequence to the exam. I find it easier to start off in mom's lap. I do the quiet things where I need quiet first, so I'm going to listen to the lungs and the heart before the baby gets cranked up crying. So I try to get the quiet things done first, and then move to things that are more apt to cause crying, such as looking in the ears, looking in the mouth, and then of course looking at patency of the rectum, looking at the genitalia, all those things that may get the baby stirred up. And a lot of it too depends on the baby's age and whether it's awake or asleep at the start. If it's sleeping, get the quiet things out of the way first. If it's not, then you may, depending on the age of the patient, I may play a little bit with it. I may give it a toy to hold, or if I have little covers that fit on my stethoscope that have little faces on them, and so I may do that. If it's an older child that has a doll or an animal with it, sometimes I'll do, if the baby's child is awake and alert, then I'll go ahead and show them what I'm going to do on their doll or their stuffed animal or on their mom, so they get an idea of what's going to be happening and that it's not going to hurt them. The general exam sequence is to look at general inspection, and of course look at hair distribution, eyes, placement of the eyes, size of the head in relation to the body, the extremities, all of those things. Chest, lungs, and heart are next because we need quiet to listen to those. Abdomen is next. Head and neck. Make sure that you, especially in children that have upper respiratory, that you're checking for flexible neck and the lack of, or the absence of nuchal rigidity, because they are at risk, of course, for meningitis. So you want to always note that, whether or not their neck is flexible and not stiff. Movement of upper and lower extremities, genitalia, patency of the rectum, neurologic, looking in the eyes, looking at their back and spine, and of course observing general behavior. Here's a clinician listening here to a heart and the lungs of a young child, and he looks pretty inquisitive there and can't decide what he's going to do about this situation yet, but that's a good way to start. And of course having mom hold them as much as possible is always is good, especially for the year to 18-month-old, because they can have some anxiety about what's going on and suspicion of new people. So it's as much as you can get done with mom helping out is great. With children, of course, we look at skills and development as we do in all children, and this is a great time too to be talking with mom about anticipatory guidance and what's going to be happening next. But throwing a ball, building block towers, drawing geometric figures or coloring, evaluating gait, jumping, hopping, and range of motion, and these can be done in the mode of play. Very often I'll sit on the floor and throw a ball to the child, or we'll build a block tower. We might do some drawing or coloring, and then I'll have them show me how to hop on one foot or whatever, depending on where they are with their developmental task. Observe them climbing onto the lap or onto the table, bending over, stooping, recovering. All those are ways to assess without making it apparent that that's what you're doing. The child sitting on the parent's lap, you can look at upper and lower extremities, head and neck, chest, heart, and lungs. With them relatively supine, still on the lap, you can loosen the diaper and look at the abdomen. You can flip them over then and look at spine. a lot of this done, with the younger child, particularly in the lap. Excuse me. Inspecting older children as they bend forward and touch their toes, observing posture from all angles, anterior, posterior, and lateral views, looking at the evenness of shoulders and hips, and observing their gait. And this is, of course, very important here. It shows child bending over here. The child then returns to the parent's lap. You inspect the eyes. You perform the otoscopic exam. Evaluate the hearing. Inspect the nasal mucosa, mouth, and pharynx. And as I said, most children, as they get a little older, they have may have a little anxiety with this, although I find some are curious. I may tell them I'm looking for bunny tails in their ears, and of course they think that's funny, and I'll say, oop, there he went, and I'll look on the other side, and oop, just missed him. And I ask, let's look in your mouth and see if he hopped in there. There are different ways to make this fun, and you'll find your own spiel that works for you. I find approaching it from a more playful type of interaction tends to work a little better if the child's not already upset when they come in. If a kid comes in just crying and just grabbing onto mom or dad and pulling their shirt off, because they're so scared, you just go in there, do what you got to do, get done with it. There are some children that no matter how you try to interact with them, they're just not going to do it. They're fearful. In those cases, you want to try to just be as efficient as you can, tell parents how they can help holding the child. I have had some where we've had to have the MA come in and help hold the child so I can look at them. It just depends, but you'll know when you walk in the room pretty much how the visit's going to go and how you have to approach the child. And I prefer the more pleasant, playful way of doing it, but sometimes it doesn't happen. With pregnant women, same as for the adult, pregnancy does require extensive abdominal and pelvic evaluation to assess not only the mom status, but also fetal well-being. And later in pregnancy, the woman may find it difficult to assume the supine position without experiencing hypotension. So place them in that position only when it's necessary. Try some alternatives like putting them at, kind of in that 45-degree position or up a little bit more than that so that they don't have these difficulties. Older adults, inspection sequence is pretty much the same, but again, just as with the pregnant woman, we have to think about special considerations for some positions. The lithotomy position for an older woman may not work, especially if she's had a hip replacement or she has pain in her hip or arthritis. We may have to be a little more creative and use like a knee chest or maybe a side lying. I mean, there are all kinds of things that you can do to assess, to do the well woman or needed assessment. So you just have to approach it a little bit different way depending on their functional status. And this goes for anybody really that's got an injury or other type of handicap or a disease that limits their function. You have to be a little more creative in how to deal with that. In the patient who is dying, and we see a lot of these in primary care and work in conjunction with hospice or home care in many cases, they still need your commitment. Although these entities tend to have their medical directors, it's not the same as you, the primary care provider that's known them and taken care of them for years, continuing to be involved. In this time, close friends, families, and significant others need your attention sometimes more than the patients do. It's, express that you feel sad for them. It's okay to do that, and let them know that you feel bad about what is happening to them and their family member. I have many patients that I've seen over the years, older patients who passed on, and just being there for them, even though you can't fix the problem, is so important, and they need to know that you do care about them and that you are providing your support, your thought, your prayers, whatever feels comfortable to you, to them during this time of need. The other thing I would add here is that you can't assume patients will behave predictably or will respond to suggestions and instructions. We call adherence to instructions compliance, and it's something you should address with your patients. And it's one reason that I give patients options and let them choose what will work for them, or give them different approaches to managing their health, because they have to be invested in it. Compliance takes two people. It takes a provider that's giving accurate and adequate information, and a patient responding with things that responding and choosing an option that's going to work for them and their lifestyle. So if you make too many changes for a patient, especially one that is already having difficulty with compliance, then they're apt not to do any of them. So sometimes it's baby steps with patients, and if you can get them to do one thing and that becomes a habit, then you can move to the next thing and the next thing. You'll get to know your patients. You'll know who's going to do things that are optimum for their health, and some that may need a little bit of a different approach, an incremental approach, or some encouragement. There are some controlling factors that contribute to this, and this is the nature of the relationship you've developed, and recognizing that the patient can choose to do what you want them to or not, and your success in communicating the basics of their condition so they understand the importance of doing what you've asked them to do, and the clarity of your instructions. How difficult is it to understand, and will they remember it when they get home? Make it as simple as possible. Sometimes I'll write down the important 3 steps for patients so that they can stick it on their fridge and they know what things they need to do for me. This is particularly important with older patients who may have a lot going on already, and you're adding more things for them to do. This becomes a very difficult request, and so we want to try to make it as easy for them to understand, and in turn we need to understand the value the patient places on resolving the problem. An example of this is smoking cessation. If somebody doesn't want to quit smoking, then all of your efforts will come to naught if they really don't want to do it. There are also times when a patient's refusal to comply may be appropriate. If they don't understand instructions, or they don't want to take the meds wrong, that could certainly be a problem. Most interactions with patients are going to be very unique. As I mentioned, everybody's different, so we have to be adaptable and flexible. And you also have to know your own biases and constrain them and not judge patients. We can't live in their skin or walk in their shoes, so we don't know the other challenges many times that they are faced with, and so we may not totally understand all the reasons for non-compliance when it occurs. So we have to be reserve our judgments or constrain those so that we come across as a partner and not someone who's judging them in their healthcare efforts. Even when the solution seems obvious, make sure that you've gotten all the information. Try to understand. For instance, if you prescribe a really expensive medication and the patient doesn't comply with what you've asked them to do, you might want to explore their finances. Maybe it's a choice between eating and buying medication. Those are things that we have to just really explore and be open to in terms of compliance. The history and performance of the physical exam are the heart and soul and mind of the alliance with the patient. Even though we have all these labs and all the technology now, it never takes the place of the thorough history and interview and the exam, which build rapport with the patients and invest them in their health care. You become the organizer of information, and for many patients you'll be the medical home. So make sure your service to the patient is well documented and is evidence-based and competent. Should there ever be a legal challenge to your effort, you'll be so glad that you documented your efforts and that the record is complete. Hopefully this information is helpful to you and will help prepare you as you move forward in your career.